I'm fortunate enough to be an investigator on this trial of MagnetisMM-3. So MagnetisMM-3 is a phase 2 trial evaluating BCMA targeting bispecific antibody, Elranatamab. So to give a brief background of who the patients that are enrolled into this trial, the patients are PI refractory, which is proteasome inhibitor refractory, IMiD refractory, that is immunomodulatory agent refractory, and these are CD38 monoclonal antibody refractory patients as well. So for these patients, the standard of care has not been as clearly defined as we would like. So BCMA became the target of choice in this patient population. And right now, as we speak, we had two CAR-Ts targeting this BCMA, which are ide-cel and cilta-cel. And we have one bispecific antibody targeting BCMA, which is teclistamab, approved in this space. And all these approvals are for the same indication. Patients should have seen 4 prior lines of therapy, and IMiD, PI, CD38 monoclonal antibody refractory. So this is a patient population that has been evaluated in MagnetisMM-3 trial. So MagnetisMM-3 trial evaluated Elranatamab among those patients that are PI, IMiD, CD38 monoclonal antibody refractory, and these patients could go on to the trial to receive 2 priming doses of Elranatamab at doses of 12 milligrams and 32 milligrams prior to a target dose of 76 milligrams, and these should be separated by 48 hours apart. And the reason why we do these priming doses is to minimize the risk of CRS by giving a large bolus of a target agent at the target dose. So with this approach, you're able to see the adverse event profile I'll be discussing in a little bit. You would be able to see minimizing of the adverse events, which could make it more predictable with the priming doses, and patients could receive these drugs in a much safer way. So going back to the patient population, so we saw that this is a heavily refractory patient population. Patients had seen a median of 6 prior lines of therapy. And most of these patients are pentarefractory patients, which means the patients had seen 5 prior lines of therapy. And these patients should be BCMA naive because we're evaluating the target of BCMA. And once the patients receive these dosings, the preliminary or the primary endpoint for the trial is the response rate. So the response rate is at a whopping rate of 61%. So the overall response rate, as defined by the International Myeloma Working Group, is 61%. And most of the patients that have achieved a response were deeper responses. So close to the VGPR rates are more than 58%. So when you see that heavy depths of responses among these patients that are heavily refractory, and if you have to take my word, like, we have not been used to seeing these responses in the past. Even 2 years ago, we were never able to see these responses. So that's why it makes a huge impact in this patient population that availability of a new treatment is clearly needed and clearly beneficial for this specific patient population. So now going down to the progression-free survival, what would be expected in terms of the progression-free survival? So for those patients, just like how I talked about, the PI, IMiD, CD38 monoclonal antibody refractory patients, on an average, live for a year before we had any of the BCMA targeting treatments. So here, within MagnetisMM-3 trial, with the availability of Elranatamab, the PFS at 15 months is more than 50%. So the overall survival has not been reached with the follow-up that we have at this point of time. But clearly, this shows the benefit a single agent could give in this refractory patient population. So every time when we target a drug or a target BCMA, that's specific target, it comes with its own baggage or some side effects. So understanding these side effects is very essential. So if we can give the patients the drug, you need to know the side effect profile so that you can manage the side effect profile if these are predictive toxicities. So the three side effects of interest that I would be discussing are, number one, the cytokine release syndrome. This is not uncommon. This is something that we commonly see with any of these immunotherapies, like the CAR Ts or the bispecific antibodies. It is an immune response to the myeloma cell death. And when cytokine release syndrome happens, so most the transplant and cellular therapy guidelines suggest that these could be graded, and the treatment is given based on these gradings. So anybody that that had more than a grade 2 toxicity, the patients would receive an antibody called tocilizumab to dampen these the cytokine release syndrome. So when you look across the board, these cytokine release syndrome toxicities are much higher with the CAR Ts, just as expected. When you talk about the BCMA targeting bispecific antibodies, these toxicities could be, I would call them a mini CRS. And this CRS is in the range of happens in around 60% of the patients. And none of these are grade 3 toxicities. That's a good thing. So these patients could get a tocilizumab if they go to a grade 2, but majority of these patients receive the pre-medications just as we want from giving the Elranatamab, and then the time to having the CRS is in the range of 2 days. That's a median time, and it lasts for 2 days. So this is a very predictable toxicity. And based on this available toxicity, there is a hospitalization recommended by the REMS program, which is the risk evaluation mitigation system. And this program recommends patients who receive Elranatamab in the priming doses to have a hospital stay of 48 hours after, and 1 day or 24 hours after the second priming dose, and then the patient could be released. So this is a very important aspect of how we manage the cytokine release syndrome. We also talk about the second aspect of toxicities, which are the neurotoxicities. The neurotoxicities happen in a very small fraction of patients. In here, it's called the ICANS, or the immune effector cell neurotoxicity that happens because of the immune effector therapies. So now these toxicities happen in less than 3% of the patients, and these are all low grade. This is comparably a very small fraction of patients that have these neurotoxicities, the mechanism of which we fully don't understand. Last but not the least, the infection and the cytopenias. So these cells have a unique mechanism of action. So Elranatamab has a unique mechanism of action. So it not only binds to the BCMA, it binds to the T cell and brings them in proximity so that the myeloma cell kill could be happening, and which propagates the further cell kill. So this aspect includes a lot of T cell engagement. So when the T cells are engaged, so in the process of giving these continuous dosing, there is a risk for the T cells to be not available for the other functions like protection and immune surveillance. And what happens during these periods are patients have higher risk of infections. And as you could see, in all the BCMA-directed therapies, we saw significantly lesser significantly higher rates of infections, and mostly grade 3 infections. And with the usage of Elranatamab, we're able to see that all grade infections to be in the range of around 50% or so, but the grade 3 infections are significantly lesser, in the range of around 30%. So these are good results, and if only we can manage and give these patients really good prophylaxis so that we can prevent the infectious risks, we should be able to deliver these treatments to better the benefit of the patients.